Hello and welcome to We Can Do Better, a podcast about ending poverty in our time. I am your host, Fran Quigley. I'm a law professor. Each week I go with my students to eviction court, where we represent some of the millions of people in our country who are facing the loss of their homes. Many of those people, including our clients, are also forced to skip filling prescriptions, and they often even go hungry, despite living in the richest nation in the world. We can do better. So this podcast lifts up the many people and organizations who are working to make housing, healthcare, and a decent life enforceable human rights for all. That means today we're excited to speak with Mara Heneghan, who will be talking about life-saving prescription drugs and how something called Public Pharma could finally make those medicines affordable. Mara is the director of the Health and Political Economy Project at the New Schools Institute on Race, Power, and Political Economy, which we'll hear more about, where she works on health-focused policy and programs. Mara has also served in multiple economic justice roles in her hometown of Chicago, including work on guaranteed income and medical debt cancellation. Mara, welcome to We Can Do Better.
Thank you so much, Fran. That was a wonderful intro to both myself, but also kind of the work I know we share in common.
Well, good. Well, I want to hear more about, I know our listeners are going to hear more about your background, but I also don't want to bury the lead, right, in this important work that you're doing. So the data show consistently that 4 out of every 10 Americans skip filling prescriptions because they just can't afford them. And affordability of prescription drugs is consistently at the very top of what Americans care about in terms of economic issues and frankly, their everyday life issues. And it's certainly a struggle that we see with our low-income clients. So you've been working on something called Public Pharma. And so can you tell us a little bit about what Public Pharma means and what that can do to address this crisis that we're in the middle of?
Absolutely. I think public pharma can seem like a really technical concept because we're thinking about pharmaceutical manufacturing. There's a lot of research that goes into that process, and then, kind of all the way through distribution to patients. But I think it's really at its simplest form, the public sector building the capacity in any or every part of that pharmaceutical value chain, from development to manufacturing to distribution. And in some ways, I think about it as removing the middlemen who are the source of a lot of the profiteering we see across that value chain now.
And those middlemen are enormously profitable middlemen. And you say middlemen, but the rhetoric from the pharmaceutical industry is, well, they're the creators. They're the ones who are doing the research and manufacturing the medicines. When you talk about public pharma, we talk about putting the public and government into some of those roles. I mean, how is that possible when you hear the rhetoric that we're just the genius of the pharmaceutical industry is the only reason we have these drugs to begin with?
A very important question. I think the first thing I would say is that a lot of the development happening that ends up kind of becoming privately manufactured pharmaceutical products starts with publicly funded research. That could be funded through our federal government. That could be led by researchers at public universities across the country. So there is already a lot of public investment behind those initial seeds of development. I think we also know that there's some of why the expertise to develop these pharmaceutical products live in the private sector right now is because we've hollowed out our public sector over decades. And we have previously had capacity within public institutions to do this work. And I think we can return to that relatively easily.
You've actually used the terms in writing that you've done, and we're going to link in the show notes to a couple of different articles. One is a recent article by you and Dr. Vincent Roy in U.S. News and World Report talking about I believe that the terminology uses is using drug manufacturing can and should be treated as essential public infrastructure, like roads, like police, like libraries, like other firefighting, et cetera, that we think is important for our survival and thriving, which of course medicines are as well. So is that the framing there? Does that something that you're trying to talk to folks about is in terms of public infrastructure?
Absolutely. I think about the public infrastructure piece from really government and public planning side of things. So we've seen, we can take COVID as a really recent example for a lot of listeners about what happens when medicines aren't readily available for us as a public good. There was a lot of public investment that went into vaccine development that ultimately allowed us to remain healthy and return back to a more semblance of normal life. But there was also a lot of supply chain disruptions in that during the pandemic. And right now, so much of our pharmaceutical manufacturing happens offshore, is not able to adapt to the public health needs of our communities. And so bringing those functions back into public settings and having public control over and interaction with that process, I think really serves us both from responding to crises, but also for preparing ourselves for kind of meeting everyday needs across a range of public health issues. And so I think that's the infrastructure at the government level. But I don't want to lose sight of the infrastructure at the kind of household and individual level, which is just to say that in the same way that a lot of the public institutions you mentioned provide public good at a broad level, they also provide really important individual services to people in their day-to-day lives. And so I think we have to think about public pharma both from this societal planning perspective, but also for the ease and the affordability it can bring to households across the country.
Yeah. And this is not just some hypothetical idea, right? This is happening in California right now in particular. It's been being discussed in places like New York and Michigan. So can you tell us a little bit about the CalRx, if I pronounce that, CalRx initiative for insulin in particular?
Absolutely. So CalRx is California's initiative to manufacture insulin at low cost, transparent prices and ensure it reaches Californians across the state. This initiative is a couple years old and was announced alongside a broader initiative to develop other medicines, including naloxone and soon to be albuterol distributed through a school-based system. And so I think it's really excited to see kind of this initial focus on insulin. Importantly, insulin has been off patent for 100 years. So I think to your earlier point about the ways that pharmaceutical companies need to be compensated for all of the development and research they're doing, insulin is an important case study for us to look at to understand that those myths can really fuel profiteering off of pharmaceutical products that have nothing to do with kind of that narrative at this stage. And also insulin is life-saving. It is essential for people living with type 1 diabetes. Having even just a short disruption in their ability to access insulin can result in hospitalization and even death. And so it's really critical to make sure that there's essentially no way for somebody who needs insulin to get denied insulin based on the cost. And so I think it's really exciting to see a state government understanding that responsibility and understanding the need. We see insulin rationing as a huge problem across the country based on affordability. And the CalRx's ability to start providing this at a very low cost within a couple of years of announcing the initiative, I think really shows what government can do here when it kind of sets its sights on this as a policy goal.
And by lower costs, I think if I saw something that you have written previously, that the cost is about $11 per pen, when from the for-profit industry was charging $80 for the same pen. Is that right?
Yes, and that number can go even higher depending on folks' insurance coverage, which I think is another piece of the system that Public Pharma can help us really start to spread the message around, which is essentially that list prices that are coming from pharmaceutical companies are often, from their view, the starting point for a negotiation with insurers, a negotiation with public payers through Medicare and Medicaid. And so those list prices can sometimes be deceptive, and pharma companies will turn around and say, well, no one actually pays that price. Because sometimes you'll see insulin at much higher prices than that $80 number. And I think we have to think long and hard about why those initial list prices are so high and what kind of distortions that fuels across the market. But yes, to the point about CalRx, the $11 per pen can save people tons of money. And it also means that there's ideally an affordable option if your insurance coverage for some reason isn't being accepted at the pharmacy counter. And so it can really be kind of an emergency option, even for people who do have other insurance coverage, to know that they have an available resource if and when they need it.
Right. Well, when you talk about why those prices are what they are, so I'm speaking to you from my hometown of Indianapolis, Indiana, which is also the hometown of Eli Lilly and Company. And there's been a series of actions and demonstrations by persons living with type 1 diabetes who are insulin dependent and their families outside of Eli Lilly headquarters, where they are one of those profitable companies in the world and have been for quite some time. And one of those demonstrations was a vigil by family members who had lost a loved one who could not afford their insulin. And as a result, as you said, this is a life or death question, not just a comfort or a short-term health situation. These are relatively young people who did not have good insurance coverage or couldn't afford it otherwise, and they died as so. This is no exaggeration to say your work is life-saving. So thank you for everything you and others are doing. And I also wanted to lift up what you talked about albuterol. So we do our work in eviction court. Evictions are very disproportionately young families with young children, and many of them are kids who have asthma who are dependent on albuterol. And without that medicine being affordable, those children's lives are both very difficult and sometimes even at risk. So that's exciting. That's next on the CalRx agenda is affordable, publicly provided albuterol.
Yes, from what I know, they're hoping to launch this summer. And a thing I think is really interesting here for the public pharma movement more broadly is that through this initiative, they're partnering with the Department of Public Health to distribute, to kind of create a central ordering system, basically, where public schools across the state can purchase that albuterol so it will be available in the school setting. I think it's really kind of exciting to think about how public agencies can work together here. And like you mentioned, this is a resource for a lot of children. And so having schools involved in this initiative and able to kind of ensure that they have medicines accessible to their students is really exciting and seems like an obvious next iteration of public pharma as we think about where else public agencies are already serving people and can really meet that need more easily.
Yeah, that's exciting. And so we've talked about California, but if I'm not mistaken, that Michigan and New York and maybe some other places are looking at possible public drug manufacturing as well.
Yes, they are. New York State has the New York Affordable Drug Manufacturing Act, which their legislative session just wrapped up recently. And that bill did not make it all the way through the session, but did make it much further than it had before. It's taken up by both the House and the Assembly in New York State. And I think we've got some exciting momentum going there, led actually by New York's Insulin for All chapter. Um, so I expect to see that reintroduced in future sessions. And it's been really fascinating to watch public awareness build and see legislators, I think, more interested than ever in engaging with these types of creative models for manufacturing. I will say that one, the New York's bill is modeled in part off of California's, and
Okay.
California is currently able to produce insulin through they're not doing direct manufacturing. So in my mind, it's kind of quasi public pharma. I think it's a really essential step and a really essential flag in the ground for public pharma initiatives. But they are working with a nonprofit pharmaceutical manufacturer who's doing that actual kind of that side of it. And then California is ensuring that it can be distributed. And that's a publicly funded contract. And so I think that also can get us some really interesting insight into kind of the data that is often considered proprietary information by private pharmaceutical companies, so we can continue to evolve the public pharma strategy. So New York's bill is modeled off of California's in that it gives the state, should it pass, it would give the state the ability to either do direct manufacturing itself or to contract with a nonprofit pharmaceutical manufacturer. And then in Michigan and Ohio, we see similar bills. If I'm not mistaken, Ohio's bill does not allow for direct manufacturing, but only allows for kind of working with a public-private partner or a nonprofit pharmaceutical manufacturer. So that's something to watch, I think, as we think about kind of where these bills are popping up, really trying to understand if a state is aiming to do direct manufacturing or if they're more interested in a kind of partnership at this early stage. And then we've also seen a bill signed recently in Oklahoma that allows for manufacturing as well. And so it's fun for me to see kind of where they're popping up across the country. And I think to your point earlier, it's because this is such an important issue to so many people in so many different political climates and geographic settings, and it's really an essential problem we need to solve.
Yeah, yeah. And to your point about the legislators being interested, the public being well, the public's interested, politicians are going to be interested, right? And even we have an initiative, big splashy initiative by President Trump, which I'm going to ask you about here in a few minutes. But
Hmm.
I don't want to lose the train of what's really making a difference. Spoiler alert, it's not going to be the Trump program. But when you talk about public pharma, we've talked a lot about the involvement in the manufacturing stage and the practicing of the manufacturing, et cetera. But also, you've written about the public, either at the state level, at the federal level, using its enormous purchasing power because the state level, the Medicaid purchases, et cetera, that essentially government is always pharmaceutical industry's uh, biggest customer, right? So
Hmm.
the question, I guess, is what can and as you have written about, what has the federal government already done to, and some states have already done to use that enormous purchasing power to kind of blunt the price gouging that otherwise might happen.
Absolutely. Just to make sure kind of listeners fully understand the scope of how much governments are spending in the pharmaceutical sector, governments are the purchaser of health insurance for their state, for their employees. So that can be hundreds of thousands to even millions of people, depending on the environment. They're also covering pharmaceutical costs for people who are getting care through their public systems, who are incarcerated or under the care of the state in other ways. And then, of course, we have public health insurance programs where government is the primary payer. So that's Medicare, Medicaid, CHIP. There's all of these ways in which government is already spending money in this system. And we know that at least some portion of that money is going to private pharmaceutical profits. And so I think it's just important to really conceptualize how big of a pot of money we're talking about, because that gives us some understanding of how creative we can be here. To
Right.
your point, we have Medicare drug price negotiation, which was authorized under the Biden administration's Inflation Reduction Act. And it's begun to, by being able to negotiate drug prices in this setting, as opposed to just accepting kind of a monopoly price that's been set by private pharmaceutical companies, we're seeing the federal government really being able to leverage the purchasing power that it has in the same way that I think we would expect any large private employer to do in a negotiation. We would expect kind of to happen in a functioning market. But because the government was prohibited from doing that before, private companies knew that they kind of had a captive audience here with federal money, and that the government wasn't going to suddenly stop purchasing drugs under the Medicare program. So I think it's really important to think critically about that purchasing power, to kind of use it in existing negotiations, and to also think about how we want to regulate or investigate where public money is being extracted from public systems to fuel private profits.
Right, right. And as you say, that just the idea of using negotiating power, a lot of this is getting out of uh, the worst aspects of capitalism. But that's actually just a fundamental tenet of capitalism, right? When you've
Yes.
got a lot of leverage, you're going to use it, and the government is very intentionally not done so, which of course isn't done in a vacuum either. The pharmaceutical industry is oftentimes been the leading lobbyist spender and the leading campaign spender, and so these haven't been accidental policies that have happened. But so you talk about public pharma in terms of, sometimes it's about manufacturing, sometimes it's about leveraging purchasing power, but also, the goal, of course, is to have affordable insulin for people who need it, affordable albuterol, affordable blood pressure medicines, et cetera. Um, so can you talk a little bit about kind of the even more aggressive, if you will, option of actually the government licensing on currently patented medicines to generic drug manufacturers? Because if folks don't know, just because a medicine, as you mentioned, insulin discovered more than a century ago, doesn't mean that portions of it and delivery systems aren't under patent. I think there's been some drugs that have had literally hundreds of patents. So people in my profession, lawyers, have done really good work for the pharmaceutical companies and have lots and lots of patents. So sometimes there really is some legal monopoly in the way of getting this medicines affordable to people. But the federal government in particular has options here. So can you talk a little bit about what the federal government can do? And I think in your position, and I would agree with you, should do to make medicines affordable.
Absolutely. So my disclaimer here is that I'm not a lawyer, but I get to work with a lot of lawyers who are very committed to kind of thinking creatively about how the law could serve public pharma here and ultimately serve patients. So the federal government could use its authority under kind of what is colloquially known as Section 1498, in which they'd have to provide reasonable compensation to the patent holder and then could produce whatever medicine we're kind of talking about here with a generic producer. Actually, on GLP-1s is where I see the most momentum on this push right now. There's been advocacy because from state governments or state agencies, because GLP-1 costs are consuming so much of public budgets right now. And so we've seen petitions to the U.S. Department of Health and Human Services under both the Biden administration and the Trump administration asking them to invoke Section 1498 and thus ensure that that these patents are not preventing competition in the market and preventing people from being able to access generic options for potentially life-saving medication. I think it is, as you mentioned, it is a pretty seen as a pretty controversial idea, but it is ultimately kind of the federal government understanding what a public health crisis is and what its responsibility towards people who need these medicines are.
Right, right. And I would say, again, just to keep that theme going, it's seen as an aggressive option because it's been framed as such by folks who make a whole lot of money off of the current monopolies that have been granted by government. But it's also something that's been done many, many times in U.S. history in a variety of ways. When there is a crisis, when there's a public health crisis, when there's a public safety crisis, when there's a national security crisis, the federal government has on many occasions said, okay, we're going to go in and we're going to make sure that this good is manufactured at a reasonable and available at a reasonable cost. And we will pay. Again, as you mentioned, the patent holders do get compensated. They just don't get compensated whatever number they want to gouge the public with, which is what unfortunately happens so often now. And you said you're not a lawyer, but some pointy-headed law professors, including your host today, have written about this in the past. Other people who are much more expert than I am about the technical aspects have written about it. So we'll put a couple of links in the show notes. But very, very common for this to be done, very well justified to be done, and then it becomes a question of political will. And so that might be a good time to pivot to the whole politics question. Because affording medicine is such a critical issue, as you mentioned, a bipartisan issue, it cuts across all kinds of economic spectrums. Really, it does. You do not have to be poor to struggle to afford your medicine, depending on what the medicine is and what your need for it is, and whether it's on a monopoly pricing scheme. So we have even politicians, including the President of the United States, proposing, I'm going to fix the drug pricing crisis. So we've a few months ago, we saw the rollout of something called Trump RX, and TRUMP, then RX as in prescription. And that was touted as being something that's going to make a real difference in drug pricing. So what about Trump RX? What does it do? And maybe more importantly, what doesn't it do?
Sure. So kind of at a factual basis, Trump RX is an online platform that lists dozens of medications and shows a price that might be lower than kind of you would find the list price on a manufacturer's kind of website, let's say. In my view, that's kind of the extent of what it does. If folks are familiar with Mark Cuban's Cost Plus Drug, it's relatively similar, even in the design of the website. And so I think even at the very start, it was a flashy announcement, but it wasn't necessarily an innovative idea. And then I think on the actual drivers of people's pharmaceutical costs, it does very little. And the piece you mentioned before that Dr. Victor Roy and I wrote together gets into more detail on this. But I think one of the biggest kind of gaps in this program that I would say also applies to cost plus drugs is that it doesn't interact with the insurance system. TrumpRx does not accept any insurance. It's entirely out-of-pocket purchasing. Cost plus drug will accept some insurance, but a limited number. And I think that that's, if you are somebody who has health insurance and has a kind of does not have a super high deductible, it's very unlikely that either of these platforms, but specifically TrumpRx, is going to help you, because you will be paying for out of pocket for the list price on the website, and you will still have to meet your entire deductible to get your insurance to kick in on other healthcare needs you might have. I think it's just another example of kind of the complication within our healthcare system, where it's really difficult as a consumer, which they want us to think of ourselves as, right? You have to be a responsible consumer and just kind of evaluate your options. This is a really good example of how difficult that is, because I'm now going to have to, if I need something and I'm looking online, I'm going to have to sit down and think about, okay, how many times would I have to purchase it from TrumpRx before my insurance deductible would kick in? What is the price I'm purchasing at in each system? Because price is essentially shiftable here. And so I think it's really hard to know for sure that you're getting a good deal when purchasing through TrumpRx if you have insurance. I think if you don't have insurance, there are instances where they might provide a good option for purchasing, but you still have to pay out of pocket. And so that is still a huge hurdle for a lot of people who don't have health insurance. And while a medicine might be $50, $100 here, that is a big cost for a lot of people. And so I think it's not delivering the affordability it promises to, and it's not recognizing the essential nature of interacting with the health insurance systems we all pay high premiums into. So I think it is flashy, and I think it was an acknowledgement that this is a problem the Trump administration feels like it has to show some effort in solving, but I don't think it's really attacking the underlying drivers of high pharmaceutical costs here.
Yeah. And I think to quote from your piece is about 85% of Americans with insurance for prescription drugs, their copays are going to be cheaper than what they can get, anything they can get off from Rx. And to your point, what you mentioned earlier, it's not like the president of the United States doesn't have things he can do. He can actually, in focus, you mentioned the 1498 option, and he can, to make it simple, he can actually license generic manufacturing of medicines. His administration has the ability to do this, authority provided to them by Congress long ago. So could have done better. It sounds like the Mark Cuban cost plus drug company, I wanted to ask you about that, but it sounds like that's a little better, but not much. He's still not attacking the underlying cost issues the way that Public Pharma is.
Yeah, I think I would agree that both of them kind of don't get at the long-term impact on the drivers here, which are manufacturers' pricing power, the untransparent intermediaries we talked about that are kind of at each stage siphoning some amount of money for their own profit, and then looking into insurer cost shifting and really trying to understand where the money in our system is going. Neither of them are designed to do either of those things. I think I reserve my ire for TrumpRx specifically because cost plus drugs might actually be the best, or one of the best ways a private billionaire like Mark Cuban can intervene in the system. Mm-hmm. But I think the federal government has a responsibility to use the tools and resources and authority that only the federal government has to intervene. And I think that would look really different than kind of a different version and a rebranded version of an existing platform.
Right. And follow the lead. It's disappointing that we see states like California, New York, and Michigan that they have to do this on their own, that it can't be done at the federal, hasn't been done at the federal level, hasn't been the political will to do that. So you talk in your piece as well about this is something that can be done. The tools are there. The legal ability is there. There are generic drug manufacturing companies ready to go right now if they can be licensed to do so. It could be that it's a government-run manufacturing process, but it could much more quickly and easily be government contracted manufacturing process, which is done in so many other sectors. So we don't, but it's not happening. At least it's not happening outside of the promising new efforts in California and elsewhere. What needs to happen for this to become a reality, and we to see one of the most pressing public health issues and one of the most pressing political issues actually be resolved, and life-saving medicines be something that's affordable for everyone? How do we get there politically?
It's such an important question because we have, like you mentioned, we have a lot of the tools we need. We also have brilliant research done by legal scholars and policy advocates and patients who've really testified about their firsthand experience when they can't access these medicines. And so while I always support new research and new ways of thinking, I think that some of this is building political power and building political will. To me, part of it starts with helping people understand that even if this is not an issue that they're facing currently, it's an issue that will likely touch them across their lifetime, or somebody that they love. And I think really helping put that into perspective for people can show why this is so near and dear to so many people's hearts. And I think we see the broader idea of affordable healthcare or healthcare affordability as a really politically motivating factor right now. And I think we need to make public pharma more legible to people, and so that it feels like a kind of obvious part of that healthcare affordability agenda, rather than some kind of off to the side new idea that we haven't really explored yet, which I think it gets discredited as often. I think we're going to need, so that's kind of my political awakening side of things. I think we just need to help people understand the impacts that this could have to their ability to afford medicines. And I think sometimes people feel it's too good to be true. And to me, that just shows that our system is so broken that people can't believe we have a way to solve it. And I genuinely think we have a lot of ways to solve it, actually. Um, I also think on the kind of policy side of things, we need to do more economic modeling to really start to make the case for how this can help state budgets and federal budgets. We need to, that modeling is often challenged by the fact that a lot of this data is considered proprietary. And so I think we need to be strategic about how, as we bring more public initiatives online, we're really using those as learning opportunities, not only to improve the kind of direct care patients are receiving, but also to improve public functioning as a whole and public knowledge of the system. And I think we also need to continue to uplift how harmful existing in this current system is to us all, and really sharing the stories, like you mentioned, of patient advocates here are some of the best champions for this work because they're so able to directly relate a really complicated system to the really immediate needs that people face every day.
Yes, yes. Well, we hopefully will get some folks from T1 International, which is the type 1 diabetes one of the leading patient organizations, on the show soon, as you say, that they can articulate the message in a way that none of us who are lawyers or advocates that aren't directly impacted personally can do. But I do want to shout out that I'm going to put in we'll put in the show notes a link to some work by Democracy Collaborative about why we need a public option in pharma, with some nice graphics that our friend Dana Brown, who did that work for Democracy Collaborative and now is with Vanderbilt University, is doing work, I know, as in partnership with you on this. And so we'll link to some of that. And it's just so important what you're doing is by telling people this is possible, that it's legal, that it's feasible, that it can be done. Because of course, on the other side, we have an industry that is making, well, I think, if I'm not mistaken, it's $1 trillion industry, right? We're not talking about hundreds of billions anymore. I think $1 trillion industry that is understandably existentially motivated to not let this happen because there's so much profit being made off of people's illness and struggle right now. So the fact that you're letting folks know that it doesn't have to be this way, theme of the podcast, we can do better, that we actually have this. So, and I think if I'm not mistaken, there's some polling that's a few years old, but like about 70% of voters would support government stepping in to produce generic drugs when the prices are too high. I imagine with full understanding, that number would be even higher because folks across all political across the entire political spectrum have this need or crisis either themselves or in their families. So thank you for doing that. But I want to ask you a little bit of how you got to this. And I know that you do your work from Chicago. Shout out Heartland
Mhm.
Advocacy.
Yes.
As a couple hours down the road, in Interstate 65, talking to you. And in Chicago, you worked on anti-poverty issues that are a big part of this show and a big part of our discussions every week anyway, including guaranteed income, medical debt cancellation, et cetera. What kind of work did you do? And, how does that lead you to doing the pharmaceutical public pharma work, the health justice work you're doing now?
Absolutely. I love talking to other Midwesterners on these issues because I think a lot of innovative work comes out of the Midwest, and the praises don't get sung quite as much as they should.
Yeah, shout out flyover country, right?
Yes, exactly. Um, in Chicago, I've served in public service roles, and specifically, I was director of policy for Cook County Board President Tony Preckwinkle during the pandemic, where we got to do some of the programs you mentioned. And really, I think serving during a crisis that is both impacting people's health and their immediate safety, as well as their economic security, just highlighted how interconnected those issues are. But how we often don't make policy in that vein. So prior to the pandemic, I would have described myself as doing economic justice work. I would have described myself as working kind of in policy, but I wasn't ever thinking about the connections so explicitly to our health system. I might have thought about the connections to people's health kind of outcomes, let's say, but thinking about the health system in Cook County, we're fortunate to have a public health care system. Thinking about that as a place people are interacting with government every day, where similar to eviction court, the needs that people have across their lives are really present. So, like you mentioned, representing tenants who you also know are going to struggle to afford the inhaler for their child. We have people coming into public health systems who we know don't have the money to afford food when they leave. And I think that position helped me really start to think about how I could dedicate myself to both economic justice and health justice. And I got to do programs that I think really fall in that economic justice category, like the Guaranteed Income Program, which was the largest publicly funded pilot at the time, and think about how either we're measuring health outcomes there for people and also how we're using that interaction between somebody enrolling in the Guaranteed Income Program to make sure we understand what their health needs are too. And then the medical debt cancellation program is one I'm particularly proud of. We launched the first publicly funded medical debt cancellation program in the country, funded by money from the American Rescue Plan Act, which was passed under the Biden administration. Really thinking about, we have this one-time influx of money to a local government. We know people are struggling economically. What is one of the biggest returns on investment we can make here for a one-time program that we don't know if there will be funding for moving forward because of the nature of the federal funding? And so we began canceling medical debt for residents of Cook County. And when you look at that, there's not only the kind of economic outcomes that come from that, but there's also people avoid going to the doctor if they hold medical debt because they're worried that they're re-entering an institution to which they owe money, which is understandable. People are denied care. And so really some of these programs just showed how important it is for us as policymakers or advocates to think about the interconnections between health and economic justice for people at the kind of in their day-to-day lives.
Yeah, that's great. And politically and economically astute, because they said the concern was that would be one-time dollars. It turned out they were one-time dollars, right? And standing up a program that needed to, to have its full effect to continue for 10 years wasn't going to be feasible. Unfortunately, we see that a lot in the housing and the addiction context, but paying off people's medical debt, you can do that right away, and that has an impact right away. And that's terrific. So let me go ahead and let you go with understanding that, folks, we're going to keep following Public Pharma. It's so important. It really is the answer to the challenge that we're facing. And We're going to put some links into folks can learn more about what's going on. But how, Mara, would people, continue to follow via social media or websites or what have you, what's going on with Public Pharma, what the developments are, the promising developments in California and Michigan and New York, et cetera? I mean, how would people keep up to date on what's going on?
We're excited to keep people informed through a newsletter we put out about quarterly through the Health and Political Economy Project. So people can sign up for that at our website that I can make sure we link in the show notes.
Okay.
And then follow the Institute on Race, Power, and Political Economy on Instagram, Twitter, LinkedIn as well. So we kind of love to keep people updated that way. I'd also shout out the incredible organizers with T1 International that you mentioned before. They have a lot of the momentum in this space has come from champions around affordable insulin. And so they have a really good finger on the pulse for the legislation that's moving and really important data to share. And then I'd also say I get to co-lead the Partnership for Public Pharma, which doesn't have too much of a web presence yet, but will soon. And that's an organization or a kind of emerging group of scholars and advocates and organizers who are really trying to think about where momentum can go. And so we're really eager to engage new people and to understand where this is happening across the country. So we'll have ways to join that soon. And we'll have that will be shared in the Health and Political Economy Project newsletter.
Wonderful. And so it's the Institute on Race, Power, and Political Economy from the New School. And again, we'll put the website and the website will have guidance on how folks can sign up for the newsletter. And then we'll put some links to social media and of course tag you all when we publicize the episode and the folks at T1 International. So we'll make sure that folks know how to keep up on this. And then again, hopefully in their states, and hopefully someday in the near future at the federal level, we'll have legislation moving, we'll have programs moving that will deserve and need public support because there's going to be pushback from the folks who are making billions right now, right, on the current status quo. So Mara, thank you so much for joining us on We Can Do Better. So on behalf of our clients who we see every week, thank you for what you're doing on behalf of the hundreds of millions of people, unfortunately, who are struggling to afford healthcare in the United States. Thank you for your important work. And thank you to our listeners for joining us for this conversation. Hopefully, this is another step towards health justice for all. So until that happens, we will see you next week. And remember, we can do better.